this is how it was said, and it was said in Swahili. Ukikosa kumeza tembe moja, unarudia. So that, I mean, it's, yeah, a shorter term would mean more compliance.
Absolutely.
But then there's also another issue that we also need to look at, and this is the cost of treatment when it comes to tuberculosis is still considered very costly to a majority of Kenyans, not even looking at the globe itself. So as government is working towards universal health coverage, as a doctor, what do you think needs to be done to actually lower the cost of this kind of treatment?
I think our government has been really instrumental, together with very key partners, in increasing the access to TB therapy. In the public setup, you do not pay for TB therapy. In the private setup, you may pay for some of the services, but largely the costs are not there. But then that means, even with shorter courses, that generally that means that the cost comes down for a country to really roll out the shorter course treatments. And remember, this don't just affect the pediatric population, it will also roll into the adult population. So I think that in a sense may reduce the costs. But when you talk about universal health coverage, you have to think about it beyond just the facility setup. You're thinking, okay, we have to increase access to services, but we've got to start in the community. And within the community, in terms of case detection, and link it to the lower tier facilities, which to some extent have a way of screening and diagnosing TB, and upward referral if really needed. This is still, TB treatment and TB strategy is really within the core of universal health coverage.
Now, you've mentioned something about early detection. Now, we have adapted these guidelines from WHO, and it somewhat presents a simplified diagnostic algorithm. How will this now help us early detection, especially where kids are concerned?
Yeah, that's a very important question. Children are not small adults. The way they present is different from adults in that, one, TB progresses much faster, and it can present like any other respiratory illness. You know, under 5s commonly have respiratory illnesses. Yes. Can even present as a pneumonia. So you don't expect to wait, oh, I've been coughing blood, or what have you. No, for children, we look at very subtle symptoms, like just a low-grade fever, just feels a bit warm for over 2 weeks. Or the baby's not playing as much as they usually do, you know. The weight is faltering. It's not going up as it should, and in the extreme, it's even going down. So very subtle signs. Now, what the new case detection, or let me simply put it like treatment algorithms have done, is that, one, they simplify treatment decision making for the healthcare worker, and they empower the healthcare worker. It is usually daunting to manage a child. You're like, oh, maybe it's not, let me first treat with antibiotics, let's wait it out. But then time is going and the disease is progressing in the child. So it makes clinical decision making simpler and empowers the healthcare worker to be confident to make the decision. It does still incorporate some aspects, for example, chest x-ray, but provides provision for settings where there is no chest x-ray access. So in a sense, that definitely, and we're already seeing increased case notification since January this year, when the new treatment algorithm was rolled out in the country. So we trust that this will really ramp up identification of children.